Hereby I open this academic ceremony in which Mr. Massimiliano Grassi, I hope I pronounced it correctly,
Perfectly,
will defend his academic thesis entitled Supervised Machine Learning in Psychiatry Towards Application in Clinical Practice. I would like to invite you to present a summary of your studies and the conclusion of your thesis in the next 15 minutes, and we are looking forward to your presentation. I give you the word.
Thank you, Mr. Prorector. Esteemed member of Coronal, family, friends, and colleague, in the next 15 minutes, I'm going to present a summary of my PhD dissertation, Supervised Machine Learning in Psychiatry Towards Application in Clinical Practice. Mental disorders are among the most widespread and burdensome disorders worldwide, but currently, the current psychiatric treatment and prevention strategies just show a partial efficacy. So one thing that has been proposed to improve their efficacy is to move from the current evidence-based system that relies on diagnosis-based clinical guidelines to the so-called personalized medicine approach. That is then recommend a tailoring of clinical decisions, but always based on science and evidence-based, based on each patient-specific characteristics, not just the diagnosis. Of course, to achieve this, we need to develop models, tools that are able to support clinicians in their tailored decision-making process, especially the complex one. One way to do this is using supervised machine learning. So what is machine learning? Machine learning is a field at the crossroad of computer science, statistics, mathematics, that allow computer to learn without being explicitly programmed. Or to say in another way, that allow to extract automatically patterns from data. Just to give an example, let's say we want to develop an algorithm for the prediction of the response to a certain treatment, starting from some clinical characteristic of the patient. We first need to collect a sample of patients, both assessing the input information, those we want to use as predictive information, and also whether they respond or not to the treatment. When we have this sample, we can apply a training procedure, and with this, then, as an output, we have the predictive algorithm. It's important to highlight that we don't need to know the rules to achieve this prediction. We don't need to be able to handcraft this algorithm. This is gonna be automatically extracted from the sample. Then, of course, when we have the algorithm, we can apply to new cases, so we can get to the desired estimate output. There are several opportunities opened by the use of supervised machine learning. First of all, this may allow developing algorithms that would have been impossible otherwise to develop, simply because currently we still don't know how to make these predictions. When we have the algorithm, of course, then we can use it in clinical practice as a support of clinicians in their complex decision-making tasks, and eventually we may be able to arrive to an automatization of some clinical tasks. Given the promise, in the literature, there's hundreds of scientific papers, sometimes reporting astonishing results, but at the same time, we face a general lack of use in clinical practice. There may be several reasons for this, but we can say that for sure, in order to translate these algorithms as part of the clinical practice, we first need to being able to develop algorithms that use just clinical information that can be easily collected in clinical practice. And of course, as much as any other medical device or medical procedure, we need to provide sound evidence or their effectiveness and safety before any translation. Can this be achieved? So the overall aims of the 5 studies presented in this dissertation, first of all, is demonstrating that it's possible to achieve clinical relevant prediction just using easy to collect information, and then providing an estimate of the expected accuracy in clinical practice, starting from very early stages of the development. The first 3 studies dealt with the development of an algorithm for the 3-year predictions of the conversion from mild cognitive impairment to Alzheimer's disease, starting from the very early stages of development to a later stage. The first study dealt with the development of an algorithm for the 2-year prediction for remission in obsessive compulsive disorder and its testing in multiple clinical settings. The last study didn't deal instead about the development of an algorithm, but presented an extensive clinical validation of a software that uses supervised machine learning to perform automatic Z-staging in polysomnography. For time reason, we are going to focus on the first two in this presentation. Starting from the first, so the task was developing an algorithm for the 3-year conversion from MCI to Alzheimer's disease. MCI is a preliminary state of cognitive decline that, however, doesn't affect severely or significantly the functioning in daily life of the patient. We know that 20 to 40% will eventually convert to Alzheimer's in the next 3 years. For this initial study and development, we used data from a multi-center longitudinal study was running in Miami area. We just had 61 patients with MCI, so we decided to enlarge our sample, considering also people with pre-MCI, that's an even earlier stage of cognitive decline. Regarding the predictive variables, of all the information we had, we decided to select just those pieces that can be considered easy to be collected in clinical practice, such as demographic data, clinical description, neuropsychological assessment, cardiovascular risk, and also a visual rating performed by the neurologist of the brain atrophy. This because in literature there's plenty of papers presenting algorithms to perform this kind of prediction, but most of them, especially those that are more performant, actually use information that, yes, can be collected in research, but instead they become very hard to achieve a widespread use in clinical practice. At this stage, we didn't have enough data, and it was at an early stage, so we decided not to create a clear split between testing and training, but we used the so-called cross-validation paradigm that, in brief, we progressively held out part of the data, we trained the algorithm in the other part, and tested in the held out part of the sample, and so forth, going on while you cover the entire sample. This is a preliminary study. Results were very high, not just in the entire sample, but also the accuracy focusing on the MCI sample. But at this stage, we wanted to be able to use the data from the same study also to get to a better evidence of the soundness of our algorithm. So we designed another study. In this case, we use transfer learning as a way to provide an indirect testing of the algorithm. So what we did, we took the algorithm, as used before, we trained it instead to discriminate Alzheimer's disorder and normal cognition. Once we achieved that, we translate its application back to people with MCI. And in this case, a determination of Alzheimer's disease was considered like a prediction of conversion. A determination of normal cognition was considered a determination instead of a non-prediction of conversion. The underlying assumption is that people with MCI already show, even if unrecognized, characteristic typical of Alzheimer's disease. And in this case, we were able to enforce a train and test independence. And with this, we, as expected, found reduced performance, but still good. Now we move to the third study. In this case, we went to using a much larger sample of 550 subjects with MCI, coming from the ADNI data set. We further wanted to restrict the set of predictors. In this case, for example, there's no information related to imaging. And in this study, instead, we created not only a train test independence. That's important. We want an algorithm that is going to be able to be used not just in the data we use for training, but in new patients, but also a site independence. That means that the data used in the training set came from different centers that don't use for the test set. This is because we want also algorithms that are able to generalize to new clinical settings. Also in this case, we found good performances, but also we can develop the algorithms so that we can increase sensitivity at the expense of specificity, and we did this because we envisioned a potential clinical use of this algorithm as an initial first cost-effective screening tool that can initially screen out with confidence part of the subject, leaving just the other subjects for potentially more invasive or more expensive investigations. And in this case, our algorithm showed that it could screen out already 30% of people as confidently non-converters. The fourth study instead dealt with the development of an algorithm for the 2-year prediction of remission of obsessive compulsive disorder. Once again, we use a large naturalistic multi-center study, possibly the largest observational study ever performed for obsessive compulsive disorder. Several centers from the Netherlands contributed, including Maastricht University. Data from this study are very representative of the clinical setting because basically no exclusion criteria. There's an extensive assessment of clinical and social demographic and the social condition of these patients. We made a step further. So instead of just creating a test and training dependence, we took the data coming from the center who contributed the most. We trained our algorithm there. Then we applied the algorithm in data coming from 5 additional centers. With this, we were not just able to provide the average performance when the algorithm is applied in new centers. Instead, we were able to test the performance in each of these centers. And this was very important because on average, we can see that we achieved a moderate clinical performance. But when we enter in each single center, we found a very large inter-center variation. And this is important. So for the next step, it's not just that we need to try to improve the performance of the algorithm, but instead, before any clinical translation, is necessary to achieve a stability, no matter which are the clinics where this algorithm is going to be used. Of course, there's room for future improvements for these studies, as much for all the studies, including supervised machine learning. First of all, it's not just important to use those information that are easy to be collected in clinical practice, but the effort should be to achieve the minimal set of information that can provide a good prediction, because we want to create these algorithms as much cost-effective as possible, pushing for even stronger independence between train and testing. We want data coming from different geographical settings, or we want data coming from real clinical settings that use partially different clinical protocols, for example. Interpretability is very important. We don't want to give these algorithms in the hands of the physician as black box, but we want them to be confident and understand how these perform their prediction. And also we want to eventually test what is the real impact achieved by translating these algorithms in clinical practice. As a conclusion, we may say that we have demonstrated it's possible to achieve clinically relevant performance using easy to collect information, but at the same time, it's very essential to provide sound, strong evidence of their expected performance when used in clinical practice. And we want to conclude saying that it's going to be important, even more so in the future, to bring, since the initial phases, the users inside the development process, because we want to, first of all, understand what are the most important clinical tasks we need to tackle, and also because we want to develop it so that this algorithm will have the highest impact in clinical practice when translated. And with this, I'd like to thank you for your attention, and I pass the word back to the prorector.
Thank you very much, Mr. Grassi, for your clear presentation. It was well done, compliments. We're going to start now officially with the discussion of your thesis. For your information, also for the viewers online, we have one of the opponents is online. The other ones are all here, what we then call on-site. And the opposition will be opened with Professor van Amersfoort. She is Professor of Transitional Psychiatry. She was the chair of your assessment committee and is affiliated with our Maastricht University. And I would like to give her the first word.
Thank you. Dear candidate, first of all, I would like to congratulate you with your very impressive thesis, and I extend my congratulations to your supervisors who are also online. It's consists of 5 very nice articles in a relatively new and innovative topic, very complex also, too complex for me. I think it's 40 years ago that I last did math. And they were carried out in different psychiatric populations, which is a strength, I think. And not only are they looking at predictors for clinical practice, but also chapter 6 is emphasizing the usefulness to decrease the burden on the personnel in the study on the sleeping problems. And you've demonstrated, I think, that you're capable of carrying out research independently. And as you say already in your discussion, the clinical applicability still needs time. But that's also exactly what I would like to discuss with you. I understand you're also a clinician and almost a mathematician, probably, or a computer scientist. So you can discuss and imagine both sides of the coin. And I want to focus on chapter 2 to 4, where you describe very nicely the training and the testing of an algorithm for conversion from MCI to Alzheimer's disease, and based on clinical and social demographic variables, which I think is also a strength, because so far a lot of the studies have been carried out in populations using MRI or genetic data. And if I'm right, the strongest predictors were based on the cognitive assessments and age, but age is, we cannot do that much about it. And when I'm thinking ahead what you would do next, because the results is that you have predictors, and what would be your next step if you consider these populations and you have a patient sitting in front of you in your clinic? And it turns out that she or he scores very badly on the cognitive assessment. What could you do then with this information?
Highly esteemed opponent, thank you very much for your question. You raise a very important topic in the sense that currently, apart from one single drugs, we don't have real disease-modifying treatments for Alzheimer's disease. So currently, this kind of prediction is for sure useful for clinical trials, because that would imply to be able to better select and not waste resources, to select people for clinical trial for testing potential disease modified.
So for patient stratification, for example, in clinical trials, yes.
And for clinical practice, we hope that we're going to be able to do something as soon as possible for also stop what is the clinical pathway, the decrease of cognitive impairment. I have to be honest, currently doing this is able to start earlier some kind of possibly more than disease modifying, trying to hamper the onset of symptoms, but it's not something we can do to stop completely. So a prediction at this point in time is not as clinically relevant as we hope it can be in the near future.
Yeah, the near future. That sounds very optimistic. Yeah.
Hopefully, in the near.
Yeah, and then if I go on like this, the studies you described, they used existing data. So there were data sets where you were confronted probably with a lot of problematic data or missing data, incomplete data. Now, if you were to do this model development again, what would you give as a message to us clinical researchers, how to collect data or where to focus on in order to optimize the data quality? Do you have any tips and tops?
Actually, the tip is to try to clean them as less as possible. It may sound strange, but if we want to go and bring this into clinical practice, we need data that are really realistic. So that's very different from experimental settings. And that's why also in the dissertation, I kind of say that using data from experimental settings may be not optimal for this kind of algorithms. Because I would say it's better to know in advance that the performance is not exceptional, or during the testing, we understand that we need to do a step more before we can actually translate it in clinical practice. Then, as I would say, a good part of the papers regarding machine learning in psychiatry, but in general in medicine, you see very high performances. But also from a technical point of view, you realize that translated in practice, they won't work as well as they say.
Yeah.
So
you say avoid artificial settings.
Yes.
As naturalistic as possible. But
Yes.
chapter 5 was naturalistic, no? You just said that in your presentation, where the outcome was not so easy to interpret
Yes.
it, which I won't go into detail about now. But so as naturalistic as possible. Okay, I would like to ask you also about proposition 9, and I would like to ask one of your paranymphs to read it out.
Please use the microphone.
We should not judge the decision-making performance of artificial intelligence systems more severely than how we judge the performance of human decision-making.
Thank you. Could you explain what made you write this proposition? I'm curious about the background.
So, in general, the background, I can also tell a brief story. So it happened a few years ago. It was the European Machine Learning Conference.
Yeah.
And there was a symposium about the use of machine learning in medicine. And there was one engineer presenting data that to me sounds very good, more than 80% accuracy. I can't remember exactly, it was some radiological application, but he instead sounded very disappointed, saying 80% is too low, it's never going to be used in clinical practice, there's a lot to do. And my simple comments was, but have you checked what is actually the agreement between two radiologists in this case?
Yeah, yeah.
And this happens currently in several fields. Also, for example, in autonomous driving. And we definitely know that autonomous driving is not perfect, but there's been some evidence that currently the rate of incidents is much lower than those provoked by people.
Yeah. So actually you're saying, don't be too harsh on the judgment of the machines if the quality of the human decision-making is not perfect either.
Or also, they can also be viewed as an increased the check on the quality of human judgment.
But actually, the way you have written it, I would actually, wouldn't it be better to say, don't judge the decision-making performance if you don't know the quality of the human data? Like there's a chronological order. You can only use the machines properly if the quality of the data is there. Otherwise, you might not even go that far to use the machine learning.
Yes, and I would say also in the idea of translation this in clinical practice, machine learning from a technical point of view, when you see an almost perfect prediction, you don't think, oh, I've achieved a great goal. You always think there's a bug, because we are talking about realistic data. So as much as humans can fail, also the algorithms can fail. So it's the combination of the two. We don't have to expect to have algorithms that are 100% perfect before we can think about using this in clinical practice, because that will never happen. So we need to think about when the combination will improve the single human rater. That's, to me, it's
I think it's very realistic, your view, and I thank you very much. I'm satisfied with your answer. I give the word back to the pro-rector.
Thank you very much. The opposition will be continued by Professor Hendricks. He is involved as an expertise in the treatment of anxiety disorders and depression in the elderly at the Radboud University Medical Center in Nijmegen. And of course, I'd like to thank him that he joins us today all the way from Nijmegen. And I'm gladly to give him the word.
Thank you, Prorector. Dear candidate, first of all, also my congratulations to you and your supervisors on finishing your dissertation. I also join the compliments of my colleague, Professor van Amersfoort. I always find it an exceptional achievement when researchers manage to do this alongside their busy jobs and family lives. I myself, I'm not a data scientist like you, but primarily a clinician who investigates how clinical practice can be improved by research. I mainly work with patients suffering from severe anxiety and OCD, and from this point of view, I would like nothing more than to be able to make a reliable prediction about individual treatment individual treatment outcome in advance. So I focus mainly on your chapter 5, and in this study you described, you developed an algorithm for OCD course prediction with on average a moderate performance with a significant large variation per center. And in your discussion you list some possible explanation for the varying predictability of the algorithm between these centers. I know this data set and the participating centers, and I'm also fairly familiar with the differences between them. For example, some centers only treat patients in an outpatient facility, and other centers offer inpatient treatment during several months. So there are a lot of differences. Therefore, I was not surprised by the difference of predictions found in the performance of your algorithm, and that leads me to my first question. Was the outcome of your study not already predetermined? Couldn't you foresee this? And if not, what does your study add to the treatment of OCD patients?
Highly estimated point. Thank you for your question. It could not necessarily be predetermined. Of course, there was a large chance this to happen. But first, the reason of the study was really to see, okay, let's try to, this variety of also clinical practice and people going, different kind of population going to different centers is what happens out there. So that was really the aim of the study. Let's try to be realistic. What would happen if you apply this like you would be out there? And not necessarily in the sense that there's always the doubt whether, for example, according to some to the clinical guidelines we have several treatments that you can choose among, but they're expected to have on average the same performance. So, or different kind of patients may show different characteristics, but not necessarily this characteristic may impact realistically on their course. So the idea was to test this, and the result was a large variety. As a next step, beyond waiting and collecting, using the entire data set, because we didn't use the entire data set from the NOCTA, there are some strategies developed from the machine learning community to try to create a model that maybe is less performant, but has a larger generalizability. And this mainly focus on the idea of, there are two paths to do this, basically. The easier path is to be able to collect at least a sample information from the new center and readapt your model to do this. But this will go against what is feasible with current, for example, regulatory bodies. So if you need to apply this algorithm and you need to have a strong validation, you need to go through FDI, for example. In this cannot happen. It's very hard. They're working on this, but it's very hard to make it adaptable once you've validated it. The other one is to really look into the predictors and try to find those that doesn't change a lot across settings, and also that their relationship with the outcome doesn't change a lot. It needs to use, in this case, all the sample we have with different settings and strongly investigate the data in the beginning and try to narrow down what are the input information of the algorithm. So the answer is, in this case, it was highly probable and was possibly also one of the aim to see what would happen if we did not apply this kind of correcting strategies. The next step, of course, is to try to use the entire sample and to check whether if we can achieve a good performance and a stable performance using these strategies.
Okay, thank you. But in your discussion, you mentioned differences between patients and restrictions in collected data as an important explanation for the results you found. However, one important explanation was not mentioned, and that is the competences of the therapists. And when treating patients with OCD, psychotherapy is by far the best treatment strategy. And the major problem is that huge practice variations occurs precisely in psychotherapy, and the OCD patients are not always offered the best psychological treatment. And that's also a main difference between this study and the previous studies, because Alzheimer disease and predicting the course of cognitive impairment, it's not a treatable, Alzheimer is not a treatable disease, so you have only the course and not a therapist who is causing differences in that course. And my point is that if we don't solve this huge variation between centers and individual psychotherapists, supervised machine learning will never be of clinical relevance at all. I would like to ask you to reflect on this.
Yeah. Thank you for this comment. I may say I agree in this, and that's probably one of the problems and one of the challenges of making this happen in psychiatry rather than in oncology, for example.
Mm-hmm.
Because you're absolutely right, there's a lot of variation in the way even manualized treatments, they are technically manualized, but the way they are actually performed, there's by definition a large variation. That's going to inject a lot of variation. So the question would be, even in this study, the average performance was just moderate.
Yes.
Is this moderate performance better than what we are doing right now in clinical practice, or no? Or in the end, it's pointless. Starting from the comment before, we need to understand if a moderate performance in these scenarios is still better, it's still an improvement in our clinical way to make predictions, or instead not. That would be probably the most important thing to test in the next step.
But how do you look at collecting data on the skills of therapists as a possible direction?
No, I think that cannot be done.
Why
but the problem is, can this model work somehow even without this information? Maybe not. Or maybe there are some other factors that goes beyond this and allow just a partial prediction. But you're right. It's possibly impossible to go and ask clinicians to be rated.
But why shouldn't we ask?
Sorry, we have to finish.
Okay, I'm satisfied.
I have to interrupt because we have to proceed.
The word back to the prorector.
Thank you very much, Professor Hendricks. And we will continue with Professor Dillis Paul. He was a member also of the assessment committee, is currently my secretary at this defense, and he is involved as chair in innovation in mental health care at our university, Maastricht University, and I would like to give him the word.
My sincere congratulations in this final phase of the PhD trajectory, the public defense. I highly appreciated your work and track records. You listed 24 publications and doing clinical work at the same time. It's a lot of work. As a mathematical psychologist myself, in addition to be a clinical psychologist, I'm very interested in everything that's related to clinical decision-making, indications for care, and outcome optimization. And I was highly impressed by the fact that you try to use normal clinical data, not increasing too much in costs of sophisticated assessment technologies that's probably will not be available in normal clinical care anyway. So that idea and thinking about that, I thought it was very interesting. So my congratulations also to the esteemed supervisors that engaged in this adventure. I have two questions for you. The questions are not related to factual aspects, but I just want to invite you to muse a little bit about the work you do. My first question has to do with the concept of personalized medicine, or here, personalized psychiatry. in my understanding of the field, personalizing often aims at relating subgroup assessments somewhere or another to specific differential interventions to improve the outcome. No, most of the things that you've done in this paper is not directly to improve the outcome. It's not differentiating about different strategies of care. So what do you think about the concept of personalized medicine in this context?
Highly esteemed opponent, thank you very much for this comment. So actually the definition of personalized medicine in psychiatry, I would argue it's not very clear. It's a large umbrella that can be used to include several different aspects.
Sometimes just differentiating by the fact that people are women or men is already personalized medicine. I don't think that's personalized medicine.
Well, sometimes it's called stratified medicine, just to say that it's going to be based on simple stratification of easy characteristics. But that's very important in the sense that we also wrote kind of an editorial with one of the supervisors regarding the difference between personalized and precision medicine, for example. And the end result was, as it's been used in the literature, and the end result is basically that they're very similar, just precision focus more on the biological determinants. That's how it's used. But I would say that personalized medicine, it's the moving away from just considering recommendation from an evidence-based point of view for treatment, but also to try to determine the prognosis, for example, based on the diagnosis, but really taking in consideration the entire person and different aspects, from genetics to social determinants, for example. And you're right that in my dissertation, what is missing as one of the study is the main topic, that's the prediction of treatment, or the selection of the most optimal treatment based on certain characteristics.
Okay, just to think a little bit about that. One of the things I often say is that in psychiatry, if you tried out an intervention last year, it didn't work, it might perfectly work next year. So if that fact is true, what is your predicting track record then? And how should you develop that? You accept that it's true?
I accept that it's true because maybe in that year something has changed. So from a potential use of an algorithms, maybe some of the information are stable or are something that cannot be changed, like age, for example. Something else can be changed. And the application of an algorithm with, for example, in the fourth study, chapter 5, the one regarding obsessive compulsive disorder, one of the main predictors was not just clinical severity, but also, for example, a lot of social aspects of their life, whether they had a work or not, for example. This can change, but I also want to be clear that we don't need to think about this change in the input of the algorithm as a causal reasoning, because that would be very dangerous also from a clinical perspective. Maybe
why would that be dangerous? It can lead to an iterative process that it's much more effective, basically, in optimizing care over the trajectory of developing resilience, for instance.
I think it's dangerous because, let's say we have a prediction of non-remission from a patient with obsessive compulsive disorder today. And we see that one of the predictors is he doesn't have a job. Or another one very relevant was attending social groups or organizations. It doesn't, observing that in 1 year this patient will actually end up being part of the social group, it's very different than expecting that, okay, if I change his status, if I force him to go in a social group, that causally be a change in his outcome of the remission. And that's, sometimes when also I speak with the clinicians, I fear the danger that seeing a change in one of the output and that cause a change one of the input that cause a change on the output is perceived as, okay, so if I do this, I'm for sure that output will happen. I'm going to treat that patient. But that cannot be true. We need to understand that this
But
correlation.
one of the basic issues of clinical decision making is having a good hypothesis is enough to work or to start exploring in a therapeutic strategy. It doesn't have to be the right thing.
Yeah.
Okay. I want to go to a second question. I have time for a second question. You described the fact that building an algorithm makes things predictable and you will get always the same kind of answers. I think that's a problem and not a solution. So I want to explore that a little bit. If I go to Netflix and I select a film on time traveling, I'm bombarded with only films on time traveling. That might be a poor algorithms, but I think they are the best guys in developing algorithms. So that's part of the problem, I think. If you, so my question is it not better for predicting to have fuzzy data and not over-defined pseudo-right data? You said something in your previous answer. I want to elaborate a little bit about that.
So what's deterministic is that if I give to the algorithm the same input, it will end up having the same output. And that's almost kind of the definition of an algorithm. But at the same time, I can connect, if I understood correctly the question, and I'm commenting on this, it's important to have very realistic data. Data, as much as life, is complex. And we don't want this algorithm to be able to work just in very clean scenario because they probably don't exist in clinical practice. And actually there are some studies that's more from a pure technical point of view. Training, for example, a deep learning algorithm, actually sometimes we insert manually some noise because this creates stability. May sound a paradox, but having too clean data will basically put us in a local minimum, and that's it. We are stuck. So I absolutely agree that the clinical world is already fuzzy enough. So we just need to use the real clinical data and try to achieve things with our clinical data.
But isn't it true that when an algorithm is predictable and deterministic, it might lose part of the fuzziness that the topic itself has? Mental health is fuzzy. Contextualized interactions are fuzzy.
One comment is that also in the thesis, our algorithms are deterministic in a yes or no manner. Actually, the way these algorithms work, initially they provide you it's not a real probabilistic outcome, it's more called a pseudo-probabilistic because they're not calibrated, but they give you a level of confidence of whether this is going to happen or not. And from my speaking also with clinicians, they want a yes or no determination. So tell me if this patient is going to become a patient with Alzheimer's disease or not. But actually, probably the fuzziness can be observed in this kind of probabilistic determination.
Okay.
That it's the original output of the algorithms.
Yes. Thank you.
Thank you very much. The opposition will now be continued online. So we move to Dr. Coulet. Dr. Coulet was also a member of your assessment committee, and he's affiliated with the Department of Knowledge Discovery and Predictive Modeling in Biomedicine at the French National Research Institute of Computer Sciences in Le Chesnay in France. And I'm gladly give him the word, Professor or Dr. Coulet.
Thank you very much, and thank you very much, Massimiliano, for the nice presentation. So, first of all, I would like to thank your supervisor for giving me the opportunity to discuss this very nice and inclusive work from my point of view. And I would like to thank you for sharing it in the manuscript and in today's talk. So what I would like to stress, and I think is of importance, is the interdisciplinarity of your work. Since you definitely, you discussed a lot about clinics and application of what you developed in clinics. but there is also data science, machine learning behind that. And I think what seems obvious to me today is that you master both of them. What tools are useful to build and how to build it. And that's, I think, something to highlight in your work. I would like also to add that I really appreciated that you were able to give the right positioning of your work in comparison to the state of the art. You know its quality, you also know and present its limits, and that's very appreciable. And thanks for that. So, all my congratulations for all these points and for the achieved work. So now, if I switch to questions, so I have a very first question about the chapter 3, and in particular about transfer learning. So I have a lot of interest in transfer learning. This can be summarized as reusing data or a model that has been developed for a source task to a target task. So you describe it very well, and you make use of this concept in the work you described in chapter 3. So very good. But one of the advantages there's two advantages in transfer learning. Is first that it enables to use other data, sometimes very large data, sometimes data from other fields that you're not involved or you didn't know. And it also has the advantage of being a large family of methods. So you have a bunch of methods that you can use to do transfer learning. So I was wondering if you were able to think of other data sets in psychiatry, in other fields that would be of interest to use for your application, and of other kind of transfer learning methods that may also be of interest to you with maybe this other data.
Esteemed opponent, thank you for your question. I hope I understood it correctly because the audio sometimes was not very clear, but you seem to be asking what are other potential data we can use through the concept of transfer learning. That's a very relevant question, because in this case we use Alzheimer's disease, people with normal cognition, more as a way of testing indirectly our study. The concept of transfer learning is to actually looking for a lot of data somewhere, where a task, we have a lot of data, train the algorithm, and just simply readapting the algorithm in a task where unfortunately we don't have enough data. One possibly, maybe too ambitious view in psychiatry, it would be to try to achieve, it's not exactly, it's more, I would say, more than transfer learning, it would be like a multitask learning. So can we gather data from very different data sets, or maybe data from data sets where several diagnoses, several predictions, several different tasks are possible? And can we try to create a model with this large set of data that can perform multiple tasks altogether? These have been proved in the deep learning community for different kind of tasks to be very useful. That's a question I have been for a while. Can we really try to gather together a lot of data, large studies, and eventually just fine-tune it? Can we develop like a master model that can do several things, and then we go on and we just readapt it in a more transfer learning fashion, just a single model? I don't have an answer, but that would be very, very interesting to explore as an opportunity.
Okay, thank you. And if I pursue on that and feed the discussion regarding the answers you provided earlier on the question, what to make differently if you were doing it with new data. I would say, so you said you answered continue, if I summarize how I understood it, continue to provide noisy data. But I would say, no, just provide us shareable data, or data that we can share and use, that share data so we can reuse it in our sensor learning approach. So what would be the most important, you think, to be able to share this data, or to have them noisy, or to have them in large amounts?
So I would say...
Repeat the question.
Yes, sir. So, so the question was, among having noisy data or sharing the data, or having a lot of data, among this, what is the most important thing in order to progress? I would say having noisy data is not an option in this field. They are already noisy. So that's a fact, probably. And I would say that sharing the data and having large data goes together. It's probably the only way, especially in a setting as psychiatry, where there's a lot of variety of procedures that we were discussing before, of clinical protocols, of treatment. That's something I may admit was a little bit missing in my dissertation, in the sense that I had access to some data set. Just one was an open data set. That's the ADNI one. The other one are not publicly available. And that's important because the larger, the better, I would say, especially in case of noisy data. But I would put them in a single answer, saying we need to share the data to get to enough big data to be able to accomplish what we are trying to do.
So if I move to
Sorry
second
to interrupt,
question.
Dr. Coulter, there is no time for further discussion. We have to continue, so we have to close your discussion. Thank you. And we
Okay,
have
that's very fine.
And we have to continue to the last opponent, and I'm moving to Dr. van Bronswijk. She is involved in depression.
So in chapter 2 and 3, you use multimodal input variables, including socio-demographic characteristics, clinical and neuropsychological tests, cardiovascular risk indexes, and indicators of brain atrophy. In chapter 4, you decide to use a restricted set of information. I understand that the exclusion of data could help with the feasibility of implementing this in clinical practice. Taking this aside, some studies in our field provide evidence that the use of multimodal data increases the accuracy of models. And it could be hypothesized that this better matches the multifactorial nature of psychiatric disorders. My question for you is whether you found evidence in your data, or maybe other studies, that certain data sources, sources of information, so for instance self-report or imaging results, are of a higher predictive importance compared to others? And can we say the more data sources, the better? Or should we focus on one or two modalities?
Esteemed opponent, thank you for your question. So I don't have evidence, clear evidence that one modality is better, and I guess this answer may also come to specifically to a specific disorder. It could be Alzheimer, or could be obsessive compulsive disorder or disorder. What I think is the right way to approach this is to chain the modality we want to assess in an order. So like we discussed for the chapter 4, if we can use very easy modalities, very easy information to screen out in the beginning at least a part of the patient, and then leave create an algorithm or any other strategies with more expensive, more invasive modalities as a second step, and also as a third step. This can allow to exploit all the information, all the scientific knowledge that we have, trying to make it more cost effective. That's a proposal. And I would say the very first step, as it is now, is for sure clinical characteristics, socio-demographic characteristics, and probably very soon also genetics, because the cost of, they say, I'm not sure they have achieved it already, but they say they want to allow a full genome-wide screening for $100. So very soon, all of us may have our full genomics screen available to be used. That would be a very step forward.
Thank you. So if I understand correctly, depending on the sample size, first start with a screening and then maybe go more specific with more advanced modalities. So I have a follow-up question, and that's a problem that's often occurring in prediction models, and that's the problem that you can't beat baseline severity. And meaning that if you want to predict the severity of a disease, the severity of a disease at baseline often explains most of the severity of the disease in the follow-up. And taking this further, one could say that monitoring the disease carefully over time would be a reliable alternative and maybe less work than a prediction model. My question to you is how much of your predictions in chapter 2, 3, and 4 depend on baseline severity, and if you think maybe monitoring would be a strong alternative?
Thank you for your question. I don't have an answer. I'm sure of interest, I would say that we checked of the different predictors we were using if the single most predictor was as predictive as the entire model or close, and that was not the case. So probably my answer would be that if we combine a constant check, an easy constant check of the severity, with some other moderators that we can add, that can also boost the single use of severity. But that's a good point. So basically all the studies use a cross-sectional strategy, but monitoring is absolutely the next step, especially now that we have the technologies, probably to don't call the patient anytime we want to have a monitoring of the patient, but we find strategies that without too much burden for the patient, too much cost for the patient, we can keep on monitoring. So the answer is, I guess it's a good point to think about severity as a very starting point for a constant prediction. I would probably add, if possible, some other moderators. And I expect adding some additional information, maybe just a few one can even boost the prediction of the single severity. That's my opinion.
So severity is not enough. You need
may
more
not be
predictors.
enough, but it's a matter of testing, of course.
Okay, yes. Then a final question about missing data. I noticed in chapter 2, 3, and 4 that you decided a priori to remove variables with more than 20% missing values. And also in chapter 4, you describe an imputation method for values that are still missing, taking the median for continuous variables and the mode for categorical variables. I was wondering whether you think the missing variables were missing, or the missing values were missing at random, or whether you think your imputation method matches this pattern or not. I have noticed some machine learning methods for imputation, so...
You're right, there was a limitation of those studies that's been partially improved, at least in chapter 5, in the sense that we use a better strategy, is Miss Forest, for example, that's it's proved to be not super fast to develop, but very useful. And also we decided, we had a very relevant information, so not just missing value, but we also have not an answer. And that was not considered a missing value. That was considered one of the potential class for a categorical value, because that that's important. Probably we need to define the studies in this way. So real missing because the procedure could not be applied, or collect when the patient refused to answer, for example. Because otherwise you're totally right. Simply having a lack of data doesn't give us the possibility to understand if it's missing at random or not. Probably it's not in clinical setting like psychiatry.
Yeah, thank you. I'm satisfied with the answer. Thank you. Again.
Thank you very much. Then we will proceed. Basically, our beadle is on his way to this audience. I know already. She gave me an answer here, and we wait for that. And I must ask a final question, which I can do myself too, of course. In your whole model, I'm not going to talk about gender differences, but I'm going to talk, which I notice here too, about multicultural problems. Did you look to ethical changes in these procedures, and how do you take care in your artificial model about this?
No.
You are allowed to finalize your final answer.
Okay.
If you want, you don't have to.
That information was certainly allowed in the US-based data set because I learned myself that it's normal to collect this kind of information, so all the Alzheimer's disease, not instead as much as I remember in the Nocta study, but I need to check. I didn't use it, but I guess this is very important because this information is not just a proxy for a variety of genetic differences, but it's a proxy for a lot of different information, from a cultural, from a socioeconomic, unfortunately. So that would be very relevant to use.
Well, thank you very much. I think we have to close now. Mr. Grassi, the time appointed for you for defending your thesis has now passed. The degree committee will now withdraw to discuss not so much the quality of your thesis, but in particularly the way you have defended your thesis this afternoon. I request that you and your company, online of course, will wait the results of our deliberations and I will return to this aula in about 15 or 10 minutes. Thank you very much.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes. In the meantime, let's take a closer look at Maastricht University's renowned teaching method, problem-based learning. Once the pro-rector reconvenes the session, we'll tune in and continue the live stream.
Problem-based learning, or PBL. What does that mean exactly? 3 of my fellow students and I will show you around. Every week, we analyze a different case or issue together. We discuss the case and everyone can contribute different perspectives to the group discussion. If we get stuck, our tutor helps us out and suggests what we could do next. I prefer going to the library to prepare. Here, I can focus and I have quick access to books or journals that help me understand the case. Today, I can also train my stitching skills in the Skills Lab, where you can immediately put into practice what you've learned. After a day like this, I like going to the gym to clear my head and get ready for the next day. At UM, you meet people from all around the world.
Hello guys. Some of them are doing their exchange semester here, and they often say that PBL helps them learn and retain things very easily. I can understand why. It's a very active way of learning because you have to bring your own perspective to real-life cases. You have a lot of freedom to manage your time, your studies, your hobbies, and your work. Of course, that also means a lot of responsibility. Right now, for example, I'm arranging my exchange semester in Madrid. How cool is that? In this group session, we're the managers who have to allocate the resources of a real company. This is how we put into practice what we learned this morning. Studying here means being proactive and learning to plan well. Prioritizing and performing well under stress are great skills that help you develop as a person. But now, it's time to grab a coffee at the Student Service Center.
Right now, we're at the Brightlands Camelot campus. Here we can apply knowledge from lectures and tutorials in a practical setting. This helps us understand what we have learned and further develop our lab skills. Today, we're determining the amounts of cholesterol in various products. What I really like is the project periods at the end of each semester, where we complete a full research project that includes planning, collecting data, analyzing, and presenting the findings. That way we learn how research works and we're able to see what it's like to be a real scientist. After practicals, I have to write a lab report that also helps me process everything I have learned today. has a lot of learning spaces where you can work on your own or with other students. This evening, I'm meeting my friends for a movie night organised by the MSP Study Association.
If you study law, you have to read quite a lot. Not all information is relevant, so you learn how to easily find the information you need to solve your case. In the afternoon, I have to give a presentation, so I like to practice it with a fellow student. Later today, a lawyer is giving a lecture. This will help us better understand the case we're working on. Speaking in front of a group is quite exciting the first time round, but you get used to it quickly. And having to present helps you also to adopt knowledge better. What I like the most is that we sometimes get to enter a plea in front of a real judge. These moot courts are really exciting. Now it's time for drinks with friends. Studying is important, but so is relaxing once in a while.
Just a moment. Dear Mr. Grassi, the degree committee here present has assessed the quality of the thesis and in particular the way you have defended your thesis this afternoon. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you officially the degree of doctor. Professor Schuurs is authorized to confer upon you this academic distinction in accordance with Dutch university customs, and therefore I invite your supervisor now to take officially the floor. Professor Schuurs.
All right, please. Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Massimiliano Grassi, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary and the other members of the committee and affixed with the official seal of the university.
I would like to give the word further to Professor Perner, who likes to give some laudatio to the new young doctor. Professor Perner.
Thank you very much, Professor. And we know each other for many years. I was surprised to see that it's 17 years passed since you were a young student. And what the first things I can say that I was so happy to see how much you grow as a scientist and as a man. And this made me really happy. In 2009, we were moving out from San Rafael, and you remember I had to make a choice, and I make a choice on you, and I'm very happy about this decision at that time. What are the characteristics, the words that are able to describe your curiosity? Was always curious, perseverance, freedom, and loyalty. These are all the words that I think that belong to you. And you remember some years ago, myself and Daniela Caldirò, is a very important person in your life. We try to push you to become, let's say, a researcher tenured in our team. You said, no, I want to be free. We were very upset about this at the beginning, but then we say, we have to follow this decision. And today we are very, very happy. And what I learned from that moment is if you want to keep a star with you, and I believe you will be a star, you should make him free. And this brought another evidence that you're really a loyal person. And the last point that you know that in our university, a few years ago, we started a medtech degree course with both the things together, so medicine and engineer, and trying to build a new and the future medical person that will be a very technological person. Then you are a forerunner of this, and very proud of it. So please do not stop in your street, and never forget to listen, all the clinical researchers, to keep your focus on the patients. So compliments, and really I'm very proud of you, Massi. And now we can give back the word to the corrector.
Very much, and I think there is also time to applaud for the laudatio. Dear Dr. Grassi, may I pronounce it now correctly? I think it feels good to be the new young doctor at this stage. Also on behalf of Maastricht University, I would like to congratulate you. You did a marvelous job, also the presentation and the defense this afternoon. And in my congratulation, I also would like to put the whole promotion team. So the whole promotion team, also the one who are online available over there. Also, thank you very much for guiding this new young doctor to this new degree. I also would like to put your wife there. She is desperately making some pictures from us here. And thank you very much. And I think it is a great opportunity. I enjoyed it myself too, as a prorector. I was a little bit intrigued with all the questions about the differences, which hasn't been answered yet. One of the final questions between personalized medicine and precision medicine. I really would like to have this point made clearer. And I think we have to close now. I would like to thank also the members basically who joined us here on the Corona from online. Professor Coulter, thank you again that you joined us. For those who are online, back in Italy maybe, back in Milano, I have no idea, but I would like to thank them too that they joined this online defense. And by saying this, I'm going to close. And for close, I have an official hammer here. So I close this event, and I'm very pleased to notice that we will going to have a small reception with you. But before that, we're going to make a picture here in this audience with basically all the members on the screen available. And after that, I finalized. So thank you very much. I close, and we're going to make a picture.